ובכן, אז אנא, אני מבקש מכם להתרכז במקרה הראשון, והיות ויש לנו מספר אורחים מחול, אני אקריא את זה באנגלית, אוקיי? אז אנחנו מדברים על case number 1, a 66 years old male patient presented with anterior wall ST elevation MI, hypertension, dyslipidemia, and family history of coronary artery disease. If we can close the doors, we'll have more focus and more concentration in the room. He was referred to primary PCI and underwent stenting to the proximal LAD using DES science. So it's a second generation DES. Reflow with STEMI3 was achieved. A mild stenosis of 40% in the RCA was demonstrated, did not require intervention. He remained with mild to moderate LV dysfunction. The EF is 47%, owing to anterior septal wall motion abnormality. Medical treatment, aspirin, ticagrelor, ramipril, Crestor, and Controloc. And during the following year, he was admitted once due to non-specific chest pain and discharged the following day after ischemic etiology was ruled out using stress echo that was negative for ischemia. He had no episode of unusual bleeding. He arrived at your clinic for his 1-year follow-up examination. He's asymptomatic and his hemoglobin is 14.2. The question at hand, DAPT continuation. Now please pay attention to the answers, and at the end I would ask you to choose one of the 6 options depicted here. What would be your recommendation? Continue with DAPT at the same dose, so we are talking about Brilinta. Continue with DAPT at lower dose of Brilinta, pending upon availability, of course, so it's 60 milligram twice a day instead of 90 milligram twice a day as option number 1. Discontinue DAPT, continue with aspirin alone. This is option number 3. Option number 4, replace Brilinta with clopidogrel, but continue DAPT. Option number 5, perform DAPT score and act accordingly. Score above or below 2. For those of you, we'll have a reminder based on the recent JAMA publication. Let the patient decide, this is option number 6, after discussing with him the risks and advantages of continue or discontinuation of DAPT at this point. So number 1 is continue with DAPT at Brilinta 90 twice a day. Number 2 is continue DAPT with Brilinta 60 twice a day. Continue DAPT with aspirin, so discontinue DAPT and continue with aspirin alone. 4, replace Brilinta with Plavix. 5, perform DAPT score and decide based on the DAPT score. And let the patient decide after discussing 6 options, regardless now, totally disregard, cost, regulation of Kupat Cholim, just in the ideal world, in the best case scenario, what is best for the patient according to your knowledge and understanding. Please choose one option out of the 6. You have what? Just a second. Let's make sure that the system is ready. Is it, Revital? The voting system should be ready. Ready? Okay, so just vote now. We'll have 60 seconds for you to vote. Starting now. 1, 2, 3, 4, 5, or 6. You can take a little bit of salmon before voting, or you can take the salmon after voting. Are we okay with the voting? Do we get the results? No? Wow, that's disappointing. That's disappointing. I read an interview last week with a CEO of a startup company who claims that they can transform all the voting system of the election in Israel into electronic voting system. He said, I don't understand how we vote with ptakim in you know, this era of, so maybe it's better to have ptakim rather than, how are we doing? How are we doing? Can we vote again? We have the results? Okay, so let's show us the results, please. Can you show us the results? Can you show us the results? Revital? Can we get the results? Next case. Why next case? We want to see the results. Can we? Okay, okay. Never lose hope. Can we see the results? Okay, so option number 1, continue DAPT with 90 milligram Brilinta twice daily, 8%. Continue DAPT with low Brilinta 60, 14%. Discontinue DAPT with aspirin, 42%. Replace Brilinta with clopidogrel, only 3%. Interesting, this is a new concept, but nevertheless, 21% voted for perform the DAPT score, 21%, and 12% would discuss with the patient and let the patient decide. So let's do the same exercise now, same patient, exactly the same patient, same details, but one change. Instead of 1 year of Brilinta, it would be same patient, same details with Efient, with prasugrel. And we'll have the 1 year examination and ask you whether to continue DAPT according to the 6 identical options. Continue with DAPT at the same dose, which means prasugrel 10 milligram, discontinue DAPT, continue with aspirin, replace prasugrel with clopidogrel, or replace prasugrel with ticagrelor. 4 options here. Same case, instead of Brilinta, it's prasugrel, and the 4 options as you see it here. Please vote. You see, we are getting better and better from each vote. At the end, we'll do fine. Okay, so the winner is here, discontinue DAPT and continue aspirin alone, which, by the way, was the majority vote, not really majority, but was the highest vote in the previous one. So let's continue and see what is the DAPT score according to the recent JAMA publication. The DAPT score is indeed zero, which means if we look here at the cumulative incidence between 12 and 30 months based on the DAPT trial, you see here continue with thiopyridine treatment in green versus placebo. So stent thrombosis or myocardial infarction, you see the numbers, the percentage here, death MI, infarction or stroke, and gastro moderate to severe bleeding is higher. So according to the DAPT score, it's actually match your intuition, and the DAPT score would not advocate prolongation of DAPT in this case, okay? So this is the first case. Now we are going to the second case, which is somewhat different. This is a 76 years old female patient presented with inferior wall non-STEMI MI, hypertension, dyslipidemia, and diabetes mellitus is the medical background. She underwent successful PCI, 90% stenosis lesion in the proximal RCA using DES, which is Resolute, again second generation, with restoration of TIMI3 flow, amide stenosis 40% in the LAD, and 40% in the circumflex was demonstrated, did not require intervention. On echo, preserved LV function with mild infero-posterior wall motion abnormality. The patient had prior PCI to the RCA in 2009, and the stent in the distal vessel was patent. The medical treatment, aspirin, ticagrelor 90 twice daily, ramipril, Lipitor, Cardiloc, Januvia, and Controloc. During the following year, she was admitted once due to effort angina and dyspnea, but ischemic etiology was ruled out with non-invasive stress test. SPECT was negative for ischemia. Also, due to an episode of conjunctival hemorrhage, ticagrelor was discontinued for 5 days after consulting with the cardiologist, and was resumed later on up to the 1-year follow-up. She arrived at your clinic for her 1-year follow-up examination. She is asymptomatic, and her hemoglobin is 12.8 and stable. So again, the question, DAPT continuation. Now, what would be your recommendation? Continue with DAPT at the same dose, 90 milligram twice daily. Continue with DAPT at lower dose, 60 milligram of ticagrelor twice daily. Discontinue DAPT, continue with aspirin only. Replace ticagrelor with clopidogrel and continue DAPT. Perform DAPT score and act accordingly, above or below 2. Let the patient decide after discussing with him or with her the risk and advantages of continuing or discontinuation of DAPT at this point. Please vote for this case. 1 to 6. One option, please. Okay, so let's see the vote here. So option number 1, continue 90 milligram, 6%. Option number 2, 60 milligram, 14%. Discontinue DAPT, in this case, and continue with aspirin, 48%. 9% would switch from ticagrelor to clopidogrel, but would continue DAPT. 23% would perform the DAPT score, and I presume decide accordingly, and nobody would let the patient have the final decision. So let's see, it's very interesting because in this case, we applied the DAPT score, and the DAPT score is high, it's 2, which means by the DAPT data that continued versus discontinued DAPT from 12 months to 30 months means stent thrombosis or myocardial infarction percentage of 2.8% versus 4.7%. The composite of death, MI or stroke, 5% versus 6.8%. And moderate to severe bleeding of 1.8% versus 1.4%. So the trade-off here is certainly in favor of continuing DAPT rather than stopping the medication. In this case, we are talking about ticagrelor. So I would like to ask you now, after you saw the DAPT score, whether you would implement the DAPT score in your clinical practice to decide on DAPT duration. Yes or no? Okay, so yes is 69% and no is 31%. It's very interesting. Again, we are talking about a new, fresh paper. The one advice I would like to tell you is that for those that voted either yes or no, please read the paper. It is very, very important to read the paper from A to Z and to look at all the details in this paper. But we are sort of early adopter, at least in this room. Let me ask you another question, which is yes and no. And the question is, would you change your recommendation on case number 2 after you saw the DAPT score? Would you change your recommendation based on the DAPT score that I shared with you? Yes is 1 and no is 2. Please vote again. Would you change your recommendation on case number 2 based on the DAPT score? I remind you, DAPT score was 2. So who would change the recommendation? Please raise your hand. Anybody would change? Who would not change the recommendation after seeing the DAPT score? Okay, so on the one hand, you would, I mean, more than 2/3 would decide based on the DAPT score. On the other hand, they would not change the recommendation. Very interesting. Okay, let's go to the last case. A different case, 57 years old male patient. By the way, all the cases are based on real patient. This is not a fiction, these are real patients. Presented with anterior wall ST elevation MI and cardiogenic shock, heavy smoking, dyslipidemia, family history of coronary disease, and left carotid stenosis of moderate stenosis. He underwent primary PCI of the ostial LAD using 2DS, again second generation or 0, and the left main across the ostial circumflex to the LAD. Reflow with STEMI 3 was achieved. A PCI to significant stenosis in the RCA was also performed in the same setting. He remained with moderate plus LV dysfunction, moderate to severe, owing to anteroseptal wall motion abnormality. The medical treatment is aspirin, prasugrel, ramipril, Crestor, carvedilol, spironolactone, and omeprazole. During the following year, he stopped smoking but was admitted twice due to angina. Coronary angiography demonstrated patent stents with mild irregularities in the native arteries. 8 months following the MI, upper GI bleeding occurred, hemoglobin dropped to 7.6, gastroscopy showed 2 gastric polyps that were clipped. He received blood transfusion, 2 PEC cells, and IV PPIs. DAPT was intermittent, it was actually interrupted for 1 week. Discharged with clopidogrel alone. Follow-up gastroscopy was performed after 2 months with normal hemoglobin, and then aspirin was restarted. He arrived at your clinic 13 months following the MI. He is asymptomatic with some mild weakness. Aspirin was discontinued by his family doctor. So right now the patient is treated using clopidogrel alone. Now the question at hand, how to continue with the antiplatelets medication. Okay, so this is the case, and these are the options. Option number 1, continue with clopidogrel alone. Option number 2, continue with aspirin alone. Option number 3, discontinue clopidogrel and start ticagrelor alone. Option number 4, discontinue clopidogrel and re-administer DAPT with aspirin and ticagrelor. Option number 5, continue clopidogrel alone, but perform platelet function test for platelet reactivity. If platelet reactivity is inadequate, exchange for ticagrelor. So these are the options. Please vote about this case. Okay, so again, very interesting distribution. For option number 1, continue with clopidogrel alone, 39%. For option number 2, continue with aspirin alone, 70%. Option number 3, which is discontinue clopidogrel and start ticagrelor alone, only 5%. 9% voted in favor of discontinue clopidogrel and re-administer DAPT with aspirin and ticagrelor, and 30% voted in favor of continue clopidogrel alone but perform platelet function test for platelet reactivity, and if platelet reactivity is inadequate, exchange to ticagrelor. I think this was an interesting exercise. What strikes me, and I hope you share this impression with me, that there is no consensus. Okay, we are all practicing in Israel. We know the studies, we know the evidence, we hear and read the data, and there is no consensus among peers and colleagues about this topic, which makes it very interesting and timely. And this is the reason we are all here, to share the knowledge and the update and to hear more about the topic of DAPT continuation or discontinuation.